I know many of you in this room, and it's really it's very heart-wrenching to me in a way because I'm seeing people living with melanoma, a lot of you in here, and I'm saying that in a good way, not in a bad way, because what I hope you will get from this talk is that the prognosis, the outlook for melanoma in general is extremely good. I don't see melanoma anymore as dying with melanoma, but as living with melanoma, and perhaps worrying about a second or third melanoma, but being cured from the melanomas that we see. And that's one of my main take-home points for what I'm going to be discussing, even though I'm going to be discussing surgical management. So for me, I'm just so glad that this room is as big as it is, and these rooms are going to get bigger because we're just going to cure most patients. And you guys can all come and hear about sunscreen, and that's great. So I think that's one thing I want to bring up. The other issue is that we, not just at the Cleveland Clinic, but in general, melanoma caring physicians are in a continuity. And you're going to see some overlap between my talks and the other talks. That's because we're not siloed. We all work together, and where one ends, the other one begins. And it's good to have overlap. So we understand what each other knows and thinks and believes in, so that we can come together as a group to take the best care of our patients. I tried my best to limit the type of pictures, because I am the surgeon in the room, to not show you anything too gory or too much for a non-physician. There are a couple of specimens that may be in there. I hope that's not too much, but pretty much as I could, I replaced what I could with cartoons. So not my own, but the couple things that, if I had more time, I would like to talk even more about the post-surgical follow-up, and if any of you want to speak to me afterwards, I'm happy to do that. So with that, I'm just going to mention I do have a few conflict of interest, and I'm going to talk a little bit, one or two slides, about Castle Biosciences, which I do have a conflict of interest. I'll tell you that ahead of time. I'm not advocating it. I just want to bring it up for information. All right, so I'm going to focus heavily on what my patients ask me and what I then tell them. Okay, for many of you, you've heard this before. The vast majority of melanoma is cured, and the vast majority of those cures are cured by surgery. So I'm going to be talking to you about a lot about where a lot of the really good stuff happens, luckily. And some of this you saw before, but the bottom line is from stage 0 through stage 3, which is all operable melanoma, that's 95% of melanoma. And even in stage 4, and less now because we're curing people even without surgery, but we do operate sometimes on stage 4 melanoma as well. So that's a lot of patients of the melanoma group that are treated by surgeons. Thus why I'm being asked to speak today. And you heard about the incidence. In 2020, it's going to be 1 in 40. It's really going up. I'll tell you something interesting. The state of Ohio has the 6th largest population in the United States. I don't know if you knew that, but we're 5th in melanoma. And it's probably similar to why Northern Europeans have very, very high rates of melanoma, because what do Ohio people like to do in the winter? Like all the people in Scandinavia, they go to hot places. And when you go to Florida, and the Floridians do their jogging at 6 o'clock in the morning, and during the shopping during the middle of the day, and then they go back on the beach. Who's on the beach? People from Ohio. So I think that's part of it. And so even though we're talking about it like sort of our daily lives here, but something to think about isn't just when we're working and being at home, but also our time on vacation. And it's not just for us, but of course, as you heard earlier, our children. Okay, so and you heard some of this before. It is mind-boggling to think, though, in 1950 there were less than 30,000 cases, and there's 3 times plus that in this year, as you heard previously. And so I guess the point of that slide was the increases there are the number of surgeons and other non-surgeon melanoma physicians and nurse practitioners and so on are keeping up with the supply. I think we are, but I think now with some of the successes, a lot of physicians and caregivers want to treat melanoma because there is so much success, and I think that will help keep up with the demand. So generally, my role as a surgeon is post-biopsy. So many times people are like, what does a melanoma look like to you? And to me, it looks like a healing biopsy most of the time. And it's not, a lot of what Dr. Vitamin showed is what you will see at a dermatologist's office. Occasionally, patients will come with a mass, and I'll be asked to biopsy that, and that will come back melanoma. But ultimately, the biopsy is the gateway to what we're going to do for these patients. I think you know, the people from AIM mentioned how they're going to be collecting these type of primary tissues. There is so much information, but also how we're going to treat all of you is based on that, including, are we going to get preoperative imaging? What else are we going to do prior to ultimately giving you your surgical plan? Technically, you're never supposed to do a shave biopsy according to the National Cancer Institute. And you're supposed to do for a biopsy of a melanoma what's called an excisional biopsy, where you take a little bit of normal looking tissue around and go a little bit deep to to the lesion that you're concerned about. Again, we don't know it's melanoma, but many times patients are still coming in with what's called a shave biopsy, because you can see that there on your left, and on your right, and sort of in the middle, is a punch biopsy. And those sometimes don't completely give us all the information. Sometimes we go back and do a re-biopsy, but many times we take what we have and we move forward with it. And so here's a patient with a large melanoma of the heel, one of mine, who had a couple punch biopsies. And I can tell you, the punch biopsies said whatever it said, melanoma in situ, an early melanoma, but we re-resected that to get more information. And with that, we were able to give the patient the appropriate plan. But then this happens to us all the time. This is what I see: a healing shave biopsy, or multiple. Which one is the melanoma? That also becomes difficult. In fact, I had a patient today who's on the surgery for tomorrow, who I had to actually find their dermatologist because we couldn't remember which, not me, a patient and my PA didn't have exactly the map of which one of these right next to each other biopsies were the melanoma. And that patient was being injected for tomorrow's surgery, and the nuclear medicine doctor was calling me because we're going to do what's called lymphatic mapping, and I'll get to that later. Another issue for me is these kind of patients, lots of moles, and I can tell you, sometimes you give this another week, you barely can see those biopsy areas. They're almost healed. And which one is it? Especially if they took part of one. These are issues we as surgeons have to deal with often. And boy, we're looking at the rest of that back and wondering, oh my gosh, how many of these other ones could be melanoma? They may none of them be, but I have to think about that when I'm caring for these patients. So time does not permit me to go through all the details of everything I'm going to show you today. However, people will ask me, what does that mean? What? I have stage 4 melanoma? It says right there, level 4. Well, there's something called Clark's level, and sometimes people freak out when they see Clark's level 4 and 5. We don't even use that anymore, but it defines how deep the melanoma goes into the skin. That's why it's important that we go deep enough to figure that out. And we used to use it often, but because of other ways of looking at thickness and other characteristics under the microscope, that has been deemed unnecessary. It's superfluous to all the other factors that we're looking for. And based on these, we will give you your appropriate what's called T stage. There's actually 3 parts of staging: the primary tumor, the T stage, your lymph nodes, the N stage, and anywhere else in your body, the M as a Mary stage. And we only worry about those based on different risks. So if your risk of the T is high enough, we worry about the N. And if your risk of the N is high enough, we worry about the M. And so I bring this up because I tell this when I give this lecture to surgeons, that if your pathology report doesn't have all that information on it, there's something wrong with that pathology report. And it's one of the reasons why we at the Cleveland Clinic not only request but almost demand that we have it reread at our institution. We trust our pathologists the best, and we know they're going to give us all the important information to create a plan for our patients. But as I mentioned earlier, many patients come in with a shave biopsy, and I can tell you we did a research paper here, and we found that more than half of the patients had a shave biopsy, and more than half of those shave biopsies, it didn't go deep enough. So we'll never know, ever, how deep the melanoma is. And you can't go back and re-resect it and sort of put the pieces together. And so we have to go with what we have, and I'll discuss that in a bit. But it, believe it or not, can affect what we do to our patients ultimately, and because of that, many surgeons will treat the patients a little bit more aggressively to make up for the ambiguity of that information. And this is just a study to show, though, luckily, even if patients don't get the ideal biopsy, and remember, there are many reasons why people get shave biopsies. There is such high demand to be to see a dermatologist, that in many places there's a 6-month waiting time frame, and you multiply that by multiple patients who might come in who need 30 to 50 lesions on their bodies to be checked, of which 5 might need to be biopsied. There's just not enough time in the day. So shave biopsies for what will end up being mostly benign lesions are what's used very commonly. But the good news is, if you look at most studies, and I'll just skip to here, regardless of the type of biopsy, these multitude of surgeons that treat these patients did not increase the death rate in these patients that were studied. Meaning, despite the fact that in many cases we don't have all the information we wanted, at least overall, it does not affect the ultimate survival of those patients. So we move forward with what we have, and then we hope, based on data like this, that we'll end up doing just as good for our patients had we had all the information. So I want to talk a little bit about staging. This comes up to me all the time. I tell you about the T, the N, and the M. And ultimately, there is a staging system by the American Joint Committee on Cancer, AJCC, and you can actually pull this up, and this, based on the information for your T, your N, and your M, you can figure out what stage you are. But what I want to point out, really, again, is sort of the positive information that's happening. Because of better staging, we're able to do better for our patients, both in telling them the prognosis, but also treatment. So, for instance, the previous version of the AJCC staging system is in the dotted lines. The colors are the same stage. So these are stage 1A and 1B. These are based on their T, their N, and their M. We make them a stage 1A, a stage 1B. But what you see is that the dotted lines are lower than the solid lines. Those solid lines are the newer ones that we're using. So those stage 1s are doing better. That's fantastic, right? And I mean, we're talking about 10-year survival rates of 90 whatever plus %, which is fantastic. Look at here. This is stage 2 disease. Again, all the dotted lines. This is the staging system we used last year for like 10 years before. Look how much better they're getting. Way better. I mean, in some cases, 10, 20% better survival with, your stage 2A with a 5-year survival of 95%, for instance. And even stage 3 has significantly improved. Now, there is this new stage 3D, which is still a rare finding, but part of it could be that some of them are being moved there. But overall, I think it has to do with better staging, better treatment algorithms, and so on. And people ask me, well, how is this possible? So the reason is, we think, is what's called it's the Will Rogers phenomenon, is I guess how it's best called. In the time of the gold rush, people from Oklahoma were moving to California, right? And of course, the Oklahomans didn't really like that, and they felt that the ones who were leaving were stupid, and that the Californians were even stupider, so that the Oklahomans got smarter, and the Californians got smarter at the same time. And so that's basically what happened. So you have a bucket of stages that really shouldn't include a worse stage, and you have a bucket of higher stage that's missing something. So these get moved over, and ultimately both stages get better, and that's sort of what we see. So we're moving patients into better better prognostication, but also better treatment algorithms at the same time. So the take-home point of what I've just told you is that the stages that surgeons treat are the vast majority of cancers. They're way better staged, and they are getting better, with the rare exception of this rare bird called a stage 3D. And all the data I just showed you is predating all the new amazing drugs that we have for patients, which Dr. Tarhini is going to talk to you about, and I will touch a little bit on it at the very end. There are reasons why our staging systems aren't perfect. Melanoma is not a typical epithelioid cancer like lung or cervical, that it can spread sometimes through the blood and skip the lymph nodes. But in general, luckily, most of the time, it is relatively predictable. And I'll mention what a cell node biopsy is a little bit later, but we use sentinel node biopsies to figure out whether the tumor spread to the lymph nodes, which makes you a stage 3, but still, the majority of deaths are in patients who are cell node biopsy negative. So how is that possible? Because a small percentage times a very large number can still be bigger than a large percentage of a much smaller number. So we still need to figure out what to do, even if we do this cell node biopsy, which I will describe. It's not perfect, and we need to still figure out how to risk stratify our patients. Luckily, though, still the risk is getting lower. And so this is the couple slides I mentioned about Castle Biosciences. This is the first of what will probably be many companies that are working on genetic strategies using the primary tissue that was originally biopsied to figure out if you're high risk, regardless of all the other AJCC staging characteristics, and it's to be added on to that. So without going into too much detail, the good news is we are starting to find other ways of risk adjusting patients and treating and following them accordingly. So for a preoperative workup, I get this asked all the time, are you going to get a PET scan, a CT scan? The reality is our major guidelines tell us, besides whatever operative, preoperative workup you need, really isn't much that we have to do unless you're symptomatic. If you have no palpable lymph nodes, even a very thick tumor, technically, if the patient is completely healthy, requires no preoperative imaging, even though there is a small chance that that patient might be harboring worse cancer in them. And the reason is because it's relatively rare, thank God, at the time the patient presents to the surgeon. Again, we get imaging only when there's symptoms driven. The other issue is, what about this PET CT? That's the best, right? The problem with PET CTs is, yeah, it'll pick up slightly smaller tumors than a regular CAT scan, but there's a huge amount of false positives, what we would call red herrings. So patients get this, and 4 out of 10, you're chasing after probably something that's not even cancer, delaying treatment, scaring the, what other our patients, all unnecessarily, costing a lot of money, and we have a limited amount of PET CT slots for patients who might need them. So it's all about trying to take care of every patient at the same time while not under-treating our patients at the same time. All right, so what do we do on newly managed melanoma? One of the questions is, how don't we have to treat me today, right now? And we did a study here at the Cleveland Clinic that was published in the Journal of American Academy of Dermatology, which basically showed, using the largest cohort of patients from the National Cancer Database available, that timing does matter, but really only in the early melanoma. That means for stage 2 and stage 3, it didn't really matter. But for stage 1, after 30 days, every 30 days made you higher risk. So I'm not saying I wouldn't want to treat all of our melanomas quickly, but certainly for stage 1. And why, in some ways, is that the most important? Because stage 1, if you think about it, could be treated by a plethora of physicians. Plastic surgeons, general surgeons, surgical oncologists, dermatologists, ENTs, and so on, some of whom keep up with the literature, but not everyone. Because it's basically a wide local excision, can be done under local anesthesia in an office. So almost even a family practitioner could do it. So that's so many physicians. So it's really important for us to use this data, not just to educate our patients, but actually to educate the physicians. So the primary site, basically, again, why do we take so much normal looking skin? We cannot see with our naked eye how far the melanoma extends. And so there is a margin, a safety margin of normal looking skin that has to be done. Patients always ask me, well, how deep are you going to go? Well, the standard is in most locations, unless you're on bone or something, is to go down to the muscle enveloping fascia. That's just the standard. And I can tell you, I didn't put that slide in here. Well, we looked at over 2,000 Cleveland Clinic patients and then asked 1 year later, using standard margins, what are the chances that patient recurred at that site? It was like 0.1%. So these margins are very, very effective at the primary site. We're not talking about cure, we're just talking about controlling the primary site. And so there were lots of studies that gave us why we do what we do. Believe it or not, though, there's never really been a good head-to-head study comparing the margins that we actually do in our patients. So it's called intermediate thicknesses, which is 1 millimeter, really all the way up, if you will. We talk about 1 versus 2 versus 1/2 centimeter margins. That study has never been done. The best study to date was published in New England Journal of Medicine in greater than 2 millimeter melanoma, 1 versus 3 centimeter margins. And if you think about it, an inch is 2 point something centimeters, right? So that's more than 3 centimeters is more than an inch in every direction. That's a lot of normal looking skin, plus the melanoma itself. You can imagine the reconstruction issues that come along with that. At that time, they didn't see any differences in survival. Later on, a follow-up study published in 2016 of the same patients did, though. And so, but quite frankly, for a 2 millimeter melanoma, I'm doing 2 centimeter margins, not 1, not 3. And that data is still not based on any major prospective study, but that's what the National Cancer Comprehensive Network suggests, and that's what most surgeons use. And why don't we go deeper? Honestly, the reason is based on very old retrospective data, mainly from the 1960s. But that's what we do. We don't go deeper than muscle fascia. And there's, the NCCN is one of many guidelines. We tend to use that one in particular. Mohs, I get asked this all the time. Why not send it to Mohs? Dr. Vitamus is the chairman of dermatology, but she's also head of our Mohs group here, which is quite robust. And basically the reason is that Mohs surgery is ideal for any contiguously growing tumors. And melanoma is not always contiguous. And in addition, under a microscope can be very difficult to see versus normal tissue without special stains. And those special stains can take days to get back. And so that's why we use those predetermined margins. So there are non-surgical treatments for at least pre-melanoma, the melanoma in situ. I'm not going to get too much into it, but there are times we will use a cream instead of surgery. Again, so this is just to show a patient of mine with a normal safety margin of skin. And one can imagine that's why you end up with long scars. You want a long scar, that means your surgeon took care of all those, those little creepy crawly tentacles of melanoma that we can't see. Sometimes, I can see a few of my own here in the room. You get a skin graft because we can't close it. And sometimes we do what's called a flap. And so that's one of my patients who had a rotational flap like the woman in the cartoon. And, cartoons look great, but sometimes this is a lot of work to get from point A in your top left-hand corner to point B. This is a staged operation. But if you give us enough time and patience, we can get our patients pretty well reconstructed. All right, so cell node biopsies. We talked about that before. Melanoma most of the time spreads, if it spreads, to the lymph nodes. It was defined as sort of the guarding lymph node, the first lymph node in what's called the lymphatic system. So we have arteries that bring blood in as well as fluid, and we have veins that bring mainly blood out of our tissues. But there's a separate system called the lymphatic system that lives heavily in our skin, actually, and it travels around fluid. And those mechanics end at sort of nets that clean the lymphatic systems. They really were designed for bacteria and viruses. Unfortunately, tumors take advantage of them. We can also do something that tumors do, which is to inject various chemicals in the skin and watch how they travel, either through radiation or using fluorescent dyes. Because I want to respect everybody's time here and the other speakers, I'm just going to go through the rest of this quite quickly, but there are various considerations when to offer that to patients, but a lot of it's left up to the surgeon. And I'm going to just skip through this because it's really data, but basically there's been lots of prospective studies to prove the importance of cell node biopsy. And basically, this is what happens the day before surgery. Patients will get injected into their skin. That injection is radioactive, and then you could see that radioactivity on an X-ray. Keep in mind, this is 1/10 of a chest X-ray, so it's very little. And then usually we add a separate intraoperative dye as well, like lymphozyrin or methylene blue. All right, so I'm just going to skip through this, but one thing I want to make a point on: when you see these kind of X-rays, don't think, oh my gosh, I got 2 cancer lymph nodes. No, we all would have those pictures, but we're not getting tested like a melanoma patient is. That just means check those lymph nodes. It doesn't mean there's anything in them. Okay, so I'm going to skip through this just because of time reasons. We at the Cleveland Clinic, I will tell you, have explored and really, I think, have advanced some of the techniques in melanoma care by using newer dyes, which have reduced any false negative incidence, which means that we picked the wrong lymph node by accident. So, take-home point from cell node biopsies. We can figure out which lymph node is the most important lymph node related to your melanoma. We can pick up as little as 1 melanoma cell in that lymph node. A cubed, 1 centimeter cubed of tumor is 1 billion cells. That's what it takes to see on a CT scan. We can pick up 1 cell with a cell node biopsy. And I think that's, really important because that means we're catching it really, really early. All right, so I'm going to sort of, I think for time reasons, I'm going to stop here. I'll just we'll let you know that after the cell node biopsy is done, and if it's positive, there is some controversies whether to do more surgery. But the biggest advance right now is giving patients not more surgery, but in those patients that we call stage 3, we're giving them systemic therapy. Dr. Tarhini is going to talk about that next, and I'm going to stop here, and at the end, I'm happy to take any of your questions. Thank you.